Okay, great. I think we'll get started now as we're nearly at 11:05. So just to say a very quick welcome to our first data access and discovery webinar of 2023. Thank you so much for joining us today. Just before we get started, just a few housekeeping rules. So these are our organisational values, and we apply them to everything we do at HDR UK, including our events. And we expect everyone else to follow them as well. We are recording today's session. If you have a question for any of our speakers, please use the Q&A function to do that. And we will be sharing the resources after the webinar today as well. So today we're going to be learning about two of the health data research hubs. So I'm delighted to welcome representatives from Discover Now, the hub for real world evidence, and Pioneer, the hub for acute care. Before I hand over to David Seymour, our Director of Infrastructure and Services here at HDR UK, I just have a couple of polls to get us started and wake us up this morning. So I'm just going to launch that now and give you a few moments to complete those, and then we'll begin. Okay. Okay, I'm just going to close that off. Stop sharing and pass over to David for our first section.
Thank you very much indeed, Ruth. Sorry, trouble coming off mute there. It looked like some interesting sort of results from the survey that just flashed up, but I only briefly caught them. But it looked like most people on the call are only somewhat or less than that familiar with the health data research hubs. So I'll just give you hopefully a quick potted history. So as on the introductory slide, I'm David Seymour. I'm the Director of Infrastructure and Services Health Data Research UK. I've been very fortunate, I guess, to have been along most of the vast majority of the journey with the hubs over the last, I guess, 3 years or so from their perspective, 4 years for the overall Digital Innovation Hub programme. For those not aware, so Health Data Research UK is the National Institute for Health Data Science. We also were very fortunate to be essentially sort of chosen by Innovate UK to lead the Digital Innovation Hub programme strand of the Data to Early Diagnosis and Precision Medicine Challenge, which was part of the Industrial Strategies Life Sciences Challenge Fund. And alongside that was work on artificial intelligence centres of excellence for digital imaging, and also works on genomics and genomic data. So Digital Innovation Hub programme is sort of what gave birth to the Health Data Research Hubs following a design and dialogue phase, and it's part of a £37.5 million investment from Innovate UK into essentially developing data as a service rather than data as a favour, to quote Jim Davis from Oxford on that one. And really the Health Data Research Hubs are part of an integrated sort of ecosystem working alongside the Health Data Research Innovation Gateway and also members of the UK Health Data Research Alliance, which again I had the sort of privilege and pleasure of convening over the last few years, and bring together a range of different custodians to really establish the best practices for the use of data at scale. And it's very much about that shift from really sort of one-to-one to many health data research ecosystem that the hubs are all about, and all of the hard work around really putting in the data curation efforts and the services associated with data access and the use of that data for a whole range of users that I think are the hallmarks of the hubs. And obviously you'll hear a lot more about two of those very shortly. I guess a couple of things I just really wanted to highlight about the hubs before you hear directly from those. One is around the really importance around collaboration. And I think this collaboration, the health data research hubs themselves were set up as collaborations of industry, academia, NHS, and with strong public involvement throughout all of their decision making. And I think that balance of public involvement alongside the provision of services to a whole range of users, including for-profit industry players, is what's sort of absolutely crucial in this space to ensure that it is considered trustworthy use and access to that data, but also to really leverage the expertise that exists across all of those different sectors. So I think collaboration, absolutely sort of hallmark of this. The second point to make is actually that the hubs have been through a really quite rigorous process of development. So those who've come on board, they've gone through a competitive process to have been selected as one of the hubs to receive funding. They've then gone through a competitive, peer review, externally, independently reviewed at a range of different milestones along the way, with a really strong focus on the sustainability of their services and their models going forward. And I think that stood them in really, really good stead for, I guess, two of the things that have sort of occurred through the course of their journey. One of which, of course, is the COVID-19 pandemic, which I think hit roughly about 3 months after the launch of individual hubs, particularly the first wave of the hubs. And secondly, I think more positively, the recent investment through the NHS England Data for R&D programme of £200 million in the range of these secure data environments or trusted research environments, and also data-enabled clinical trials work. So I think that the hubs are in good shape. In addition to the 7 health data research hubs that were commissioned and funded as part of the Digital Innovation Hub programme, we've also got 2 further hubs that have been supported by UKRI MRC funding, and that's covering both pain and mental health on that. And I'm sure we'll send the links around so that people can see the whole range of the hub services and the hubs themselves that are available to the range of users that we've got. But I think that's probably enough from me for now, and more important that we pass over to the teams at the different hubs. And Ben, I think you're up first.
Thanks, David. It was a lovely introduction. I'm looking to share my screen. So I hope everyone can see my slides. I'd like to send a good morning from London, to each attendee from wherever you're joining. I hope everyone is doing well. My name is Ben Pierce. I'm head of data analytics and partnerships at Imperial College Health Partners, or ICHP, as we're known. And I'll be speaking on the Discover Now Hub, and touching based on how research involving real-world data works and what that means, but of course open to any questions from anyone in the audience at any time. Of course, looking to answer those during the Q&A session. So ICHP is a very agile organization. It's a partnership that brings together NHS providers and healthcare services. And it touches base on a number of health issues in Northwest London, but of course, looking for impact on a broader and wider scale. So I'll be focusing on real world evidence, that is the qualitative, quantitative data-informed studies that are carried out. But just please do keep in mind that this is in strong collaboration with a number of partnerships, either from the supply side, so third-party industrial, pharmaceutical partners, but as well as academic partners, universities, and with close-knit ties to NHS Trust, NHS clinicians. Each of our projects is led by a clinical lead with key expert background in leading our project involve real-world data. ICHP is also an academic health science network, or AHSN. We're quite proud of this, one of 15 in all of England. And we have that supports our ties to the NHS and understanding the real needs and how our research can give direct benefits to patient care and better equitable access to improved healthcare options. We're also, it's not on the slide, but we're an external assessment group for NICE. This became active from July of last year. And one exciting project we're currently conducting as an independent assessment of NICE activities. So lots of activities there, really. which can be broken down in a number of avenues. That could be feasibility studies. I'm quite active in retrospective studies myself, but our tool set includes ways of identifying patients for supporting recruitment or education on recruitment pathways to clinical trials, research involving health economic evaluations, expert applications of AI and machine learning, and how we have workshops that have been used recently to educate patients on what that means and how that's to be done. There's a new blog on our website on that for how kidney transplant patients were involved in learning more about this. And of course, supporting better ways that health implementation can be made accessible. So how is this done? This is done using our Discover database, which the slide says 2.5 million people. I'll show you that it's just over 2.7 based on our latest count. And the database is one of the largest in Europe. And how this works is electronic health records are provided from local authorities or GP practices, hospitals, in a number of different formats into what's called a WYSIC. And this is patient identifiable data at this first step, of course, so linking things like NHS numbers, but through careful and closely guarded methods becomes de-identified in the process of linking this information to our secure, trusted research environment that we call Discover. And this information, once de-identified, then becomes available once approved for ethical reasons and ensuring that the research questions do directly apply to benefiting the patient health aspects and options for Northwest London, and we hope on a broader scale. We can carry out research projects that involve, for example, population health management, maybe support operational planning for primary care networks, and support answering research questions from academics or third-party industry where there's real tangible outcomes from that. I'll give just a couple of examples on each of these in the next couple of slides. This is all based on most of the population in Northwest London, an extraordinarily high percentage, as it is just over 2.7 million. But if you're comfortable or experienced in looking at data, I hope this jumps out quite quickly, that the Northwest London population is rather younger than the overall population in England. However, it is extremely rich in terms of ethnicity, and therefore it can be made applicable on a wider scale, but we do have to make those considerations when we're reporting on this information. But it does allow for, with it covering a near complete population, it does allow for a proper evaluation of the data coming out of it that could be made applicable on a grand scale. And we do that by conducting a number of retrospective studies. We use the NICE real-world evidence framework. This is best practice guidance. Actually, our team supported drafting of this, which came online just last year. And what this is looking to do is to set best practices that align retrospective studies as closely to how clinical trials are carried out. And that is best done by minimizing bias. So I think, particularly with what happened in the pandemic, a lot of people are more familiar with how clinical trials are run. And when they're randomized, that means that patients can be sorted amongst one or two arms, most traditionally. And we apply several different methods of doing that to minimize confounding, covariates, minimizing measurement errors, and acknowledging, understanding where data is missing and for what reasons there's missing data, such that our projects follow along how trials are best conducted. One application of one example of a retrospective study that I'd like to point out is one involving sotrovimab. This is a monoclonal antibody. It was approved for emergency use in England from December 2021. And last year, we looked into the question of, well, how successful was it? What was the impact on patient health in terms of hospitalization or death, particularly for the Omicron subvariants BA2 and somewhat BA5. So looking between the periods of December 2021 and July 2022, we've seen that there's tangible outcomes, particularly for patients that are older and with renal disease covariates as well. And we're quite proud that our results have been cited by NICE as part of their drafted final guidance for recommending the continued use of sotrovimab. It's just one of several examples of our retrospective studies that have delivered real impact here. As another example, which is currently ongoing, I'm leading a project involving chronic kidney disease, and this is a project involving a cohort of just over 1 million patients. And what we're seeing here is a stark and clear understanding that there are far too many patients that are just not being screened and are certainly not being coded for CKD that need to be. So we're proceeding with the study, and reports will be coming out shortly on this. We also apply various range of methods for analyzing the data. I'm not going into the complex details of AI and machine learning, but we can apply this, and it must be tailored and it must be constructed and, of course, validated for the particular research question. But it's something that our data scientists are quite expert in doing, and we look forward to continue applying this for a number of research studies that we'll be taking on. I mentioned patient identification. That's not what we do in our retrospective study. That's all securely done with de-identified data. This part of our service portfolio involves allowing better support for patient recruitment to clinical trials and patient education for what those clinical trials mean. So we have over 220 GPs that have signed up for the tool that's called Farsight, that links clinical event data with identifiable data, such that GPs and hospitals can support first making aware to patients what clinical trials are ongoing and what they mean, and support for recruitment, of course, going through the consent process and ensuring that these patients are fully aware and understanding of all aspects of the clinical trial. Quite exciting as that I've set up and run a clinical trial. Recruitment can be incredibly challenging. And there are a number of aspects where clinical trials can be quite and can be quite slow, from funding to insurance to recruitment aspects and just racing against the clock. And so having these supportive tools that can strengthen our infrastructure for supporting clinical trial recruitment, it does ease aspects in a number of ways. There's also something called Northwest London Health Research Register. We have nearly 70,000 people that have been consented to be contacted regarding such clinical trials or research projects. And we like to thank every and all patients that we've engaged in through the research register and by other means, for example, our workshops through patient engagement and patient educational purposes. We're quite excited about the next steps. So where do we go from here? We have been funded and supported to move into what's called the Subnational Secure Data Environment, SNSDE, which rolls right off the tongue. And this is a new goal for us that uses the Discover Northwest London infrastructure and governance and mechanisms that we already have in place as a blueprint, applying this across all of London. This will become live from April 1st, but there are several cogs in the mechanism for how this is to be done. Several years that are in place, where in the first phase, we'll be bringing together data sets involving acute mental health, community primary care, from each of 5 ICB's integrated care boards, if you don't know what that is, within 12 months. It's an ambitious task, but we're confident that this can be done. This will then be there's the addition rather than expansion of data sets that will include several types of data from secondary care, social care as well, done in years 2 and 3 of this process. So this will be set up to have a broader but sustainable and stable way of governing these data on a London-wide access. And that's all being based on how we run things in Discover. And we're looking forward to how this can help support linked data and research approaches towards making research projects more tangible, feasible with bigger impact, and whether that's from sample size considerations or just a better representation of the general population of London, which can be made applicable on much larger ways. This also helps our goals of acknowledging public health inequalities. So rather than stigmatizing certain subgroups that are hard to reach, we are doing more to better reach these patient populations that are in dire need of better healthcare options. So with that, that's my brief overview of Discover Now, and happy to pass it on to the strong Pioneer Hub team. Thank you very much.
Thank you so much, Ben. That was great. Suzy, Liz, when you're ready.
Thank you. Yes, we're just trying to share our slides. I'm hoping you can see them now. You can. I've had a thumb up. So we're doing a double act, as you can see. My name's Liz Sapey. I'm the director of the Pioneer Hub. I'm a clinical consultant that works in acute medicine at the Queen Elizabeth Hospital in Birmingham, and I'm also a professor of the same at the University of Birmingham. I'll pass over to Suzy to introduce herself.
Thank you, and I'm Suzy Gallier, so I'm the technical director of Pioneer, looking really at all of the sort of infrastructure and data based at University Hospitals Birmingham.
So we're really pleased to talk about the Pioneer Hub, particularly after such a strong presentation from Ben from Discover Now. It's fantastic to have two of the sister hubs working together on this. And so I wanted to talk to you initially about Pioneer, what we're doing, what we've achieved so far, and opportunities for working together. There we go. Thank you. So acute care is a sort of different offering in comparison to the usual ologies that you sometimes have in terms of disease clusters. It's focused on unplanned healthcare services, and it can be any form of unplanned healthcare service or episodes based across any disease. What we have within Pioneer is ethical permissions to look at patients as they go through their journey with unplanned healthcare services, but importantly, to compare those to the population of patients that are going through standard planned care episodes to see what learnings there might be to improve care. Acute care, of course, has been in the press really from the pandemic onwards in terms of the volume of patients going through unplanned healthcare services and the impact that has on the NHS. So there's thought to be over 110 million urgent same-day contacts each year, and numbers are going up. There is a huge demand for innovation to change how we deliver services and prevent patients having to rely on acute services because their chronic diseases are managed earlier and better. We know there are significant health inequalities for patients accessing acute care services. And unfortunately, this sector has previously seen less innovation than many other health sectors. So it's something that we felt passionately about in terms of improving how care is delivered. Our vision within this is that access to highly detailed, individually linked health data, including synthetic data, supported by expert consultancy, can really transform the way we care for patients across our population. And our aim is always to improve the health and well-being for patients and our population, and to enable responsible and patient and public endorsed data sharing under license with supported analytics and consultancy. So Pioneer is an ethically and CAG-approved secure research database and analytical environment. We link patient data at an individual level across community and hospital healthcare providers. We are completely disease and organ agnostic, so it is the complete healthcare record for each individual, irrespective of what's happened to them as they've gone through life. The data is near time, so it's frequently refreshed. I think we've got a lag of about a week before it enters our research database. And from this, we're able to build bespoke data sets, including synthetic data sets, really focusing on areas of interest that our customers may have. We offer a private cloud-based system using Microsoft Azure that has been fully cybersecurity tested, and akin to Discover Now, we're pleased to say that this is the technical solution that the Midlands SDE will also be using across our joined-up population of 11 million people. We have the ability to build bespoke trusted research environments, and we also have a number of tested blueprints going from a standard to a really high-end high compute power offer. We provide transparent public oversight of data access through our Data Trust Committee, and we provide data access under license to the NHS, academic, commercial, policy or third sector organisations. I'll pass to Suzy.
Thank you. So Liz has touched on this a little bit, but we're really proud of the data that we actually offer and the expertise that we've got. The team really understand that data and have got years of experience. But what we have is 20 years worth of longitudinal data. And each year, year on year, we're getting about 1.2 million patients through, adding to that data set. They're unique. And also the strength of our sort of data is that unlike HES data, we have that sort of deep phenotype data in terms of medical laboratory tests, all of the sort of imaging reports, and all of that sort of serial readings, etc. So we can sort of link that through. We also have links in then through the HDRU gateway and Liz's links through acute care to 153 UK hospitals in terms of a snapshot audit around acute care. Plus we have our West Midlands ambulance data as well, where we sort of link that through. But if you're interested in our data, we have some infographics on our HDR UK gateway and on our website. So please do get in touch. We have some bespoke window offerings there, but also if you want to sort of come to us, we can sort of do some feasibility to see what we have on offer for you there. As mentioned, we are providing synthetic data, and that's something that we pivoted quite early on to when we realized that actually in terms of governance and sort of quick no decisions, and really to start with things like rare diseases as well, we can start that sort of AI piece, that sort of statistical summary piece quite early on. So we produce both synthetic structured data and, as on the screen here, one of our synthetic images. So all of that is then provided, and we can make that tailored and bespoke for you. So if there's something, a disease you want to sort of focus on, we can sort of look at the real data, get those parameters. We work with our clinicians very closely to make sure that really absolutely mirrors the real data. And that's really a strength of ours, is that sort of academic clinical link to make sure that we've got the sort of robust technical team, but we always have that input from our clinicians. So actually when our clinicians do look at it, they do actually say that it really does mirror that real world data. But all of that is sort of available on demand. So that infrastructure that we provide, as Liz said, that's actually very proud that that sort of has led into that SNSDE. As you say, it doesn't trip off the tongue well, does it, Ben? But in essence, we have built a series of blueprints, but if you have something very bespoke, we can work with you to actually provide that. As you might expect, we can offer the different tooling within there. So just on the right-hand side, you'll see some of those. So we can do the sort of R, Python, Julia, etc. But we can even do sort of Stata and SPSS depending on the sort of needs of our requesters. But all of that, as Liz said, we've got a very sort of for SMEs, we can offer a sort of a lower cost environment where we can sort of have shared infrastructure, but we can also provide a sort of gold standard infrastructure that we sort of built up with Microsoft and a project we did with them, which allows for big AI and compute and high compute levels there. But something that sort of is very much, we'll tailor with you, we'll make sure that you're actually onboarded correctly, and all of that meets your needs. So it's not burning too much, it's burning exactly what you actually need it to burn. In terms of our offering, these are sort of the three approaches that Pioneer has taken. So data as a service, you can approach us, we've got our sort of access form, but this is all under license. And the way we will work there is depending on whether you want the structured or unstructured data or a combination of both. But even with this particular service, what we're making sure is we're linking with our clinicians and our academics to make sure that you really get the data that you actually need to answer your question and really provide that sort of data concierge service right through. In terms of consultancy as a service, we have experts on site who can actually provide the analytics for you, provide those reports and work alongside you. So again, that can be very much something where we can tap into our clinical expertise, but all of that can be done. So we're working with regulators as well to look at some of the work they want to do there. Furthermore, we have that sort of community ability to sort of pull people through to different networks. So if there is some specific project where you want us to sort of tap into that sort of broader network that we've got, something we can really sort of facilitate. So as you might imagine, with patient data, we're very proud and careful to make sure that we follow the 5 safes. So making sure that when we assess those projects and the people applying, but also that that data is housed in a safe environment, and all of those sort of tests, as Liz said, around the sort of security of the environment. We have our data access request forms on our website, so you can download and access that, but also we have a website where you can get in touch, and we have user guides to talk you through that. But all of that makes sure that we are following due process to make sure that when our data is applied for, we have the appropriate level of access. Also with our data controller models, depending on whether, for example, we've got other trusts involved, we can work through those different models for people to get involved.
So we spoke about our public and patient engagement in this process, and that's been really at the heart of what we did and what we do. When we set up Pioneer, we spent a long time speaking to members of our population about what they hope for, what their concerns are, and how they'd like to get involved with data access decisions, as it is their data that's being utilised to answer important questions. So with them, we set up this data trust committee, and we now have 2 data trust committees running in parallel, sitting every couple of weeks because we're very busy, which is good news. And they oversee and look at every single access request that comes in. They're incredibly diverse, as you'd expect from a city like Birmingham, and 80% of them have to approve data access for that data access to go ahead. We would then like to just highlight some of the achievements that we've reached so far, but these are some headline figures, and we'd be delighted to go through those with you in more detail if necessary. We're proud to have worked with across different sectors, including large pharma, medtech, medical device, healthcare consultancy, international tech, and SMEs. And for SMEs in particular, we have packages to really help them gain access to data, which can sometimes be really difficult to do and very costly. We've worked in collaboration with a wide number of individuals and organisations, leading to over 20 publications, supporting more than £30 million of successful grant awards, and we've had data licensing agreements with more than 30 organisations. We're now on over 75 data sharing requests since our doors opened officially in the summer of 2020, with funding models confirmed, and we've enabled data access by more than 350 analysts across the world. And the thing I'm most proud about, I guess, as a clinician, is the impact that this has had on the ground. So projects that Pioneer have supported, both internal and external ones, have really influenced how care is delivered in terms of creating appropriate guidelines, checking that they're fit for purpose and with multimorbidity, and changing how decisions are made on the ground by making best use of complex data to inform those decisions. And we've put in this some impacts that we've had with specific activities, but we'll go through these very quickly so there's more time for discussion. But these go from anything to building AI tools to look at x-rays and CT scans, clinical decision support tools, making sure that prescribing is correct, and developing prognostication processes to work out what's going to happen to patients as they start their journey. Thank you, and I think we will end there.
Thank you so much. That was great. So we've got about just under 10 minutes for a few questions. And actually, I was going to ask about working with the NHS and secure data environments, but I think both from Pioneer Hub and Discover Now Hub, you covered that in your presentation. So instead, I'm going to go straight to our questions from the audience, if that's okay. And I might ask one at the end if we have enough time. So I saw we touched on a little bit there about AI, and there was a question, just trying to find it. Maybe perhaps it's been answered already. Oh, Ben has been busy answering questions. But perhaps Liz and Suzy can jump in. How do you foresee the advent of AI changing, one, the need for health data scientists, and two, the training course content for health data scientists in the UK? With sort of, there's a specific mention of master's programs offered there. So I think Ben might have answered a bit, but perhaps Suzy and Liz, you may like to add into that.
I'm delighted to take that. So at the moment, AI, of course, is a massively hot topic as an expanding. And there is sometimes a disconnect between people that are trained in AI and their understanding of the governance and laws that are around unconsented health data, the national data opt-out, and how you can appropriately access data in a safe and secure environment. HDI UK is very much part of the story in terms of connecting those communities and enhancing knowledge. We're leading on a health data week immersion course, actually, specifically to train data scientists in understanding a little bit more about governance and health data in all of its richness, and the fact that it takes quite a lot of work to take it out of the electronic health record and make it fit for research. But this is an expanding area. The things that Pioneer is really proud of is the fact that as our data is massively diverse, we're able to provide representative data to build algorithms on. And the same I know is true for Discover Now as well. And that's been a problem in the past in terms of building algorithms on data that probably hasn't been representative of the wider population. But this is an area of huge expansion, somewhere where we're seeing increased interest from our regulators thinking about things like algorithm decay and the diversity of data. And it's something that the hubs are really at the crest of in terms of, yes, providing access to data, but also equipping people with the tools and understanding they need to do so in a way that's secure, ethical, and likely to lead to patient good.
Brilliant, thank you. David, do you want to add something?
Yeah, just to, I think, I mean, the excellent answers both in the chat and obviously given there by Liz. I think the bit I'd probably add is the importance of explainable AI. And how that's a really important skill essentially for our health data scientists to develop. But I would also say that the training need also then sits with those who are expected to then use AI. And I think Ben makes the point, it's not going to replace humans, but it's maybe it's an advanced form of decision support tools, and actually the ability to take and interpret the outputs of AI becomes a really important skill for clinicians and other frontline staff as well. So I think the training is both sort of two-way, both in terms of health data scientists, but also actually a more general awareness of health data science across the broader workforce.
Absolutely, thank you so much. A question for Ben here. Does Discover Now allow recontact of participants with specific codes to invite them to participate in ethically approved studies? If so, what's the process?
Thanks, Ruth. And I'd like to thank Chris for this question because it's a perfect one. It can be challenging, not directed to Chris, but really to anyone, to understand that we have several areas of research where one is based on retrospective studies, so that's de-identified data, and another area would be this patient identification process. And that was the slide that I talked about on far side in the research register, where when there's a clinical trial that's been approved, it's been funded, it's ready to go, is looking to see, can they identify patients that are eligible that would then be contacted about the consent process that, of course, the patients would learn about and agree or not to take part in the clinical trial. So Farsight and the health register are simply the administrative tools by which, in the first case, GPs or hospitals can identify eligible patients, notify them in face-to-face meetings, as people regularly do with GPs. The GP says, look, there's this clinical trial X. I think you're eligible. Would you like to learn about the consent process and what the trial involves? So the Farsight tool is the step in between that allows the GP to be able to better help identify potentially eligible patients for these trials. So the clinical trial has already been set up. It's already been ethically approved, and then it's when the patients are informed, educated about the clinical trial. Of course, it's their decision on whether or not to take part. I hope that answers your question, Chris.
Brilliant, thank you. I don't know if Suzy and Liz want to add anything, or if we're happy to move on to another question.
I mean, happy to move on, but yes, say this is a similar service to what Pioneer offers as well, that sort of fast screen for clinical trials, and it's proving very effective in terms of increasing delivery at a very challenging time.
Absolutely. So a lovely comment, amazing presentations from you both. That's an attendee saying that, not myself, although I do agree. Can both groups say what data formats and standards are employed in their storage and supply of data?
Yeah, so we have a natural format back out of the back of our EHR, but we also look at providing it in the OMOP data format. So we can really talk to you, and we can provide sort of multiple lookup tables, or we can actually sort of provide a flat table. So it very much depends on what you need. So we're very much able to pivot accordingly. But in terms of common data models, it's OMOP that we've done.
And from my side, I'm actually putting in a citation because it can be quite technical. So I feel like I assume, Tony, you have the technical expertise, but for everyone, rather than going through several acronyms that may be lost, or I just don't want to place a letter in the wrong position, I'm putting here a paper that's open access. And for anyone, please do read it, and it perfectly describes the architecture and requirements and considerations in safely storing the data in what sort of formats within Discover Now. But thank you for that question.
Perfect, thank you. So there's a question here actually that I'd written down, and also someone has asked, so I'm going to ask that if that's okay. And it's about the use of synthetic data, mouthful to say. The person said that it's a great tool to balance bias in data, but is asking about how clinicians respond to the use of synthetic data and how they trust the outputs that's coming out through training of the data.
I'll start this one off from a sort of a clinician, since it was asking about clinicians. I feel qualified to do that one. And then if there's any technical handovers, I'll pass to Suzy for that. So synthetic data, like any kind of data, is of varying qualities, I think is the truth. And I've looked at some synthetic data as a clinician and thought, as a clinician that's an expert within this field, this feels like rubbish to me. So you get synthetic data of the quality, I think, that you deserve in terms of really thinking about how it's been developed and made. The wonderful thing about the data, the synthetic data that comes out of Pioneer, is that as a clinician, for me, looking at it, looking for those relationships that I would understand to be there, it feels really real. And that's because it's based directly on the electronic health record and the relationships we see, and that we do stringent checks with clinical experts to look to make sure those relationships you'd expect to see within clinical data are actually present. And the feedback we've had for its use has been incredibly positive in various ways. So, for example, with rare disease, we've worked very closely with a clinical colleague as part of a collaboration with industry, looking at a rare disease where these data sets were not of sufficient number to really start to develop algorithms that you could test to look for potential signals of harm at an earlier stage. So by creating a synthetic data set, we were able to start that process, started early, whilst we then, as Pioneer, went looking internationally for data sets that could also be used to address this problem, and then in fact found the data that we needed spread across Europe to build the real world data set. So the algorithm had been developed on the synthetic data, which the clinician had worked really closely with, felt really real, and then it could be deployed in this very broad and granular data from across Europe, which was able to validate its use. So in those sorts of circumstances, it can be incredibly powerful, but you have to get the quality right. So quality is everything. Suzy, I don't know if you've got anything to add.
I think the only thing I could add to that was that, as we said before, we've got a really diverse population. And again, what we don't want is seeing synthetic data coming out that is based on a skewed population, because again, all that's going to do is replicate that skew. So we're very passionate about the fact that with our diverse data, our synthetic data is equally representative and doesn't create any bias. So I think that's the other thing that people and clinicians are worried about, is what data has it been built off to create any skew or bias.
I have no comment to add, because I think it's been summarized perfectly. I mean, we're in support of it, but there has to be close consideration of how it's to be used and properly, and is it really answering the question at hand? And there needs to be close quality controls and quality checks to that.
Brilliant, thank you. And I know we're a couple of minutes over, but I just wanted to sort of ask a final question about how you imagine the future of the hubs to look like in 5 or possibly 10 years. If you could picture sort of the perfect scenario in the future, and perhaps that's to each member of our panel with 30 seconds to go, or 30 seconds each. Who wants to take it first?
Okay, should I go first? And then Ben will say it far more eloquently than us, I'm absolutely sure.
And then we'll finish on David.
I think that the hubs have started an incredible journey of bringing data sets together, bringing clinical and academic expertise to make sure those data sets feel true and right, and to utilize them in a way that has a hugely positive impact for patients and for our population. And I think that journey will continue and evolve. More and more data is becoming available, and actually to truly understand disease and population health, we need to be able to link not just health data, but think about the social determinants of health, the environmental determinants of health, meaning that greater and greater expertise is needed to weave these together. And I imagine that the hubs will evolve as SDEs come more and more to the frame across the country, but their pockets of expertise will still be incredibly necessary and welcomed as we bring more and more diversity to our data sets.
Ben?
Thank you. I'm quite excited. I'm often reminded of the COVID pandemic, and I like to use that as an example because everyone knows about it. When the variant B117 arose in England, that the only reason that came on anybody's radar is it was first picked up in a database in South Africa, and it's just a perfect example of that. When data is linked, when people have their eyes when they're on the ball and eyes are on data that is relevant to the research question, lots of very powerful information can come of that. And if we work together in a coordinated way, ensuring that data comes in safely, securely, and appropriately, and is managed with the highest control possible, so to answer the research question, to get real impact outputs with real quality, we can create some terrific change in this country to improve better health outcomes for patients in need of that. And that's the whole point. That's the business that we're in, is ensuring that we use our tools most appropriately to improve patient care and patient options for better healthcare. So I'm quite excited for the next steps. Very much looking forward to it.
I'm hearing coordination, collaboration, federation, innovation. David, do you have anything to add?
I mean, I think again, excellent answers. I think the two bits I'd probably add is I think that the need to ensure that we've got a way of working with all different parts of the life sciences, if you want, which includes obviously industry and for-profit companies, is absolutely essential to make sure there is the innovation there. Secondly, I think that actually the convergence of research and care, which again was very sharp focus in during the pandemic, I think needs to be sort of more widespread as well. And I guess the third point is we haven't really touched on today, but is the sort of the genomics and in many ways, as they describe, multi-omic data. And we'll learn there's a whole set of stuff that we don't know yet in terms of the data around the sort of multi-omics and how that will change sort of the markers of disease and how we understand disease. And that's, who knows when that will happen. It's hard to predict, but we need to make sure we've got, I guess, the infrastructure and services available to make sure that happens in a trustworthy way.
Thank you so much. And on that note, I'm going to close off today's webinar. So a huge thank you to all of our speakers and our attendees for coming along today. Thank you so much.
Thank you.
Thank you.